Oh, yes, so it's okay. Well, good afternoon, everybody. I'm Françoise Shenfield, and I've known Melanie. I think we're trying to work it out since the late 80s, when we were working at the Middlesex Hospital, of which only a little bit remained, and with Mr. Steele. And soon afterwards, a very famous professor came and had his own chair all the way from St. Mary's, not very far. Howard is here, and many of you have worked. We were down the corridor with, you were 2 floors upstairs, and everybody was at the beginning of fertility treatment, which was so exciting. Less exciting was measuring estradiol in women's urine and asking them to carry bottles of about 2 to 5 liters. But they were exciting times. I'm not saying it's less exciting now, but to have been there right at the beginning when things really took off was really something special. Endocrinology, the LHRH pump, everything which was new about PCOS. Not that we forget surgery, but it was very exciting time. So on and off, it makes what? I daren't count. Late 80s to almost 40 years.
I'm keeping it a bit quiet, Françoise.
Okay, fine. Well, now she's a professor, well deserved, after doing lots of research, many fascinating fields from premature menopause, as it was called, which is now, of course, everything changes. And we're going to listen to your lecture, Women's Health, a Long-Haul Flight. Here we are.
Well, before I start, can you hear me?
Yes.
Good, good, good. So firstly, thank you all for coming. Thank you for your message of support, and thanks to the people who are listening online. Long haul flight, why the title? It reflects my long haul career. It is more than 40 years, but it also seemed an appropriate metaphor for women's health. The term reproductive life course was, I believe, coined here by Professor Judith Stevenson. Women's health is now seen as a continuum, and my clinical work runs from paediatrics right through to menopause. So women receive healthcare through the long haul of their lifespans. Looking back at my career flight, I had a pretty good takeoff with favorable winds. I encountered some turbulence along the way, and actually I changed my flight path more than once. But there have been times, and this is one of them, where I really felt that I was flying. Though perhaps for me, now the landing pad might be in sight. So initially, I declined to give this inaugural lecture because I was suffering from imposter syndrome, that lack of confidence and self-belief that holds back the careers of many, many people, and especially women. Then I thought, well, can't be many people invited to give an inaugural lecture when they're past the usual age of retirement. So let's do it. And I hope it might give encouragement to other people, especially those who haven't taken a conventional academic pathway. And I want to publicly thank Professor Anna David for the encouragement and the support that she's always provided. So thank you, Anna. I'm sorry you can't be with us this evening. I hope you feel better soon. Well, my personal statement for UCL revolved around these headings, which I hope to illustrate in this lecture. I'd already worked at UCLH for 20 years when I applied for academic promotion. By then, I'd been awarded £4 million in grants, written over 150 publications, I'd supervised numerous postgraduates, and I'd been introduced as professor at lectures and meetings so many times it was embarrassing. But actually, I think the real achievement is to do any of that whilst a full-time NHS clinician. Because I worked as both an obstetrician and gynaecologist. I covered obstetrics on call till I was 55, and I was on labour ward till I was 60, when I became a true subspecialist. But the why me goes back a long way before that, to the formative influences on my ambitions in my career. And inaugurals are supposed to have an element of biography. So I'm going to start with an acknowledgement. This is my grandmother who brought me up, and anything that I've achieved, I owe to her. I was a small baby when my mother fell ill with tuberculosis. And it was pretty awful for my father because he'd already lost his mother to TB as a teenager in South Wales. Now, by the time I was born, streptomycin had been discovered, but treatment for this very infectious disease was still based on isolation. My mother was sent to a sanatorium, and I was left with my grandmother. Now, I was the youngest grandchild. She'd lived through 2 world wars, and she'd been in London through the Blitz. So understandably, she admired Churchill. And his motto, KBO, should perhaps be the subtitle of this talk. I'm not sure I should say it on air, because it is a little rude. But it's certainly been my path through my bereavements and divorce and bringing up the children. I just kept my head down, KBO. Well, our house was full of books, and my family prioritized education. And I was a bright child. I had scholarships through school. I went to St. Paul's Girls in London, pretty high achieving school even in those days. And that got me into Cambridge. That changed my life. It really is this beautiful. I took this photo on my phone a few weeks ago, standing on Clare Bridge. I applied to Clare College because it was just opening its doors to women after 650 years. A quick anecdote, when I went for my interview, my tutor, standing in his 3-piece suit with his watch chain in front of his mantelpiece with the decanters and the fire, said, "My dear, I voted against the admission of women to this college. Can you convince me otherwise?" That was my interview question. Well, they gave me a scholarship and I lived in this beautiful building for 2 years. Cambridge gave me freedom of thought. It gave opportunities to step outside one's subject. Actually, I spent a whole term studying tissue. And my degree is actually in social and political science. Not that I was ever very good at that, but actually sociology and psychology is a very useful background for obs and gynae. Then I went from the ivory tower down for my clinical work in the East End. It's really hard to photograph the London hospital now as it's draped in plastic sheeting here. And many of the training sites have now closed. We were at Bethnal Green, the Siemens Mission. Those were the days. Now, I started out to train as a GP in Whitechapel, but I got hooked by the labour ward. And I worked in Mile End for Peter Huntingford and Wendy Savage. And Wendy, I'm really delighted you're here with us this evening. They were the first consultants whom I saw really cared about the lives of their patients. They sat and listened to them, and they supported women in their choices. So they were way ahead of their time in practicing what we now call woman-centered care. That included abortion, and they ran a pioneering service. The split between them and the establishment led to Wendy's suspension with accusations of incompetence. Wendy was prepared to stand up and fight. Now, I was a lowly SHO, but I wrote a statement in Wendy's support. The local GPs and the local community came together. And this image shows a march down the Whitechapel Road. There was a public inquiry, she was exonerated, and subsequently not only reinstated, she was elected to the GMC and to BMA Council. And she's continued to be an inspiration to me ever since. Well, I had my own baby as a registrar, who is at home looking after her own baby this evening. I got out of the house after a few weeks in between breastfeeds to hear a lecture given by Howard Jacobs, who's in the center of this photo. I was so bowled over, I went up to him afterwards and asked for a job. So this is Howard with the fertility greats. And there are several people here whom I also considered mentors, particularly Alan Templeton at the end here, the past president of our college, Ian Cook from Sheffield, Peter Brinston. All of them I've kept in touch with. And the message here is that inspiring people become supportive mentors. You must never be afraid to ask. Well, Howard didn't really have a job, but he had ideas and he had a new machine. This is a DEXA scanner. This was my first paper, and it was in the British Medical Journal. That was 1990. It's still getting citations in 2024. We studied 200 women under the age of 40 with amenorrhea, no periods, of typical duration 3 years. Several of them had osteoporosis, like this patient whose readings are below the normal range there. And overall, their bone mass was about 15% down. Over a quarter had had a fracture. And we showed that bone loss correlated with the duration and also the degree of estrogen deficiency. We then looked at treatment with estrogen, and I will come back to this at the very end of the talk. There was a little improvement, but not very substantial at 2% a year. Now, all of that may be a bit dry to some in the audience, but the real joy of working at the Cobbold labs was the after party. Every Tuesday, after a massive clinic, we all sat down to discuss the patients we'd seen with trays of sandwiches and coffee, and the conversation would segue into the latest theatre, the restaurant openings. Charlotte Street was round the corner. And this is a recent reunion of the research team. So I think it's a lovely photo. And Anna, thank you for coming tonight. And you can see at the back there, Jerry Conway. So really multidisciplinary team with Chris, who is our ovulation induction nurse, June, our secretary who actually ran the department, John, who ran the lab, and Elfie from the lab. So we've all kept in touch all that time. My research salary was earned at the Hallam Medical Centre, where Dr. Bridget Mason, an amazing woman, an entrepreneur, turned her donor insemination practice into an IVF unit. Now, these were still the early days of IVF, as Françoise has said. Louise Brown had been born only 10 years earlier. This is the dish in which that embryo was cultured, and it's now in the Science Museum. All of these developments had taken place in that short time. Developments in pharmacology, laboratory techniques, imaging. I can't overstate how exciting it was to be working then. My IVF project was setting up egg donation. I researched hormone support and placental hormone production and showed that egg donation pregnancies were just the same as any pregnancy when it came to the placenta. This little study showed that we could give physiological HRT and create a perfect cycle. IVF doctors here will recognize we still use these, estradiol valerate, intramuscular progesterone. Well, we looked at circulating hormones, we biopsied the endometrium, and in the first 16 patients we treated, 5 got pregnant. It did seem to correlate with their endometrial development. But then my colleague down the road, Paul Serhal, who was working with Ian Kraft, showed it was all much simpler. You just give big doses and it works just fine. Now, I was lucky enough to come under the wing of Bob Edwards, the IVF pioneer, who, as well as being a genius, was a genuine and humble man. He stuck to his vision through a maelstrom of negative publicity to get IVF up and running. And that is another message for the young people here to stick to your vision. He was open in his thinking. He was incredibly foresightful. He was full of ideas. He started the journal Human Reproduction and the European Society, ESHRA, which now has 10,000 attendees in Amsterdam last week. And he was immensely supportive. He asked me to speak in a plenary session. I was still a research fellow. Now, ESHRA was a small meeting then, but gosh, I prepared carefully. To appear in the same session as R.G. Edwards, a Nobel Prize winner. I should frame this. But I think for Bob Edwards, the rewards actually came from his science and from his work. This is a Bourne Hall party. Every year they invited all the families born through IVF. And as I was working there for a while, I was invited. I mean, look at this. I remember talking to Bob on the steps of Bourne Hall and looking out at this crowd of people, toddlers and babies and happy parents. There are over 8 million babies born from IVF now. I mean, what a legacy of human happiness. Well, coming back to the more personal, when I finished my research post, I had 2 children under 5, and I had the MRCOG gold medal. My registrar post, however, was resident on call 1 in 3, nights and weekends. And for those of you unfamiliar with this, that was 84 hours a week. It was impossible. I put my research thesis in a box under the table, and I left the NHS. It took me a couple of years to return. I wanted to return because I needed job security for the children, and I was ambitious. I came back as the first part-time obs and gynae trainee in London. There were only 3 of us in the country. And I'd seen so many talented doctors leaving the specialty that they loved. It politicized me. And I think this is what UCL called external influence in my application. I became the national coordinator for women in gynecology and obstetrics. I stood as a members representative, got onto council of the college and became their flexible training advisor. And I joined the Medical Women's Federation and later became their president. I wrote this editorial for the BMJ 2002. It gained some publicity, and certainly within our specialty, we made great strides. The RCOG Manpower Committee was renamed the Workforce Committee. Working less than full time became commonplace. I had to fend off remarks about, oh, my registrars are on maternity leave again. I point out women's careers are often bimodal, and if they have a little bit of support and flexibility in that middle section when they have caring responsibilities, they continue to work and they become loyal and committed employees in the long term, the long haul. Well, in my role at the Medical Women's Federation, one of the issues was academic medicine, so I'm just going to pull that strand out. We went to the Medical Schools Council, as it was then, in the early 2000s, with data on the lack of diversity in academic medicine. We took part in the WAM report, Women in Academic Medicine. This is the Chief Medical Officer's report from 2006. And the Athena Swan Charter was started in 2005 when I was president. And as you know, our department has a gold award. But there is still work to do, and this is just a very recent example. The American Society of Clinical Oncology sat through its conference and published a study showing that when the speakers were introduced, the correct professional title and role was given to 81% of men, but only 62% of women. And on the BBC website recently, many of you will know Asma Khalil, Professor of Obstetrics, but only her older male colleague is given the professorial title. So I'm just going to sidetrack for a moment into a little bit of history. I hope you'll bear with me. Now, the MWF was founded in 1917. It was the time of the suffragettes. And actually, it carried the spirit of pioneers. We work in the EGA building, named after Elizabeth Garrett Anderson, who's centre here in the picture. So she was the first woman in Britain to qualify as a doctor, 1865. As no hospital would admit her to practice, she set up her own dispensary. And it was named the New Hospital for Women. It moved to the Euston Road in 1890. And after her death, it was named the EGA Hospital. So this is where our gynecology was sited when I began my consultant career in the 1990s. And I'm proud to be still associated with it as chairman of trustees of the EGA Hospital charity. Well, now we're in this current UCLH building, which is over the road. We've got an incredible richness of clinical work, which is the bedrock of our clinical research. So I was appointed here as an obstetrician, gynecologist, and subspecialist in reproductive medicine with a remit to improve the fertility services. It was certainly been a long haul by then. It was more than 15 years since I'd qualified. In developing the fertility services, one of the first things that struck me was the number of women who came too late. because age is the prime determinant of success from treatment. Now, I had met Peter Brodie when he assessed my training. Yeah, it's that long ago. And together with my friend Susan Bewley, we wrote my second BMJ editorial. This one is on age and reproduction. There was massive media interest, as you can see from these headlines, and this isn't all of them. Though actually the Guardian reporter there was quite okay, really. So it clearly touched a nerve, but it is important information for women. And in subsequent years, there's been a huge push for fertility education, led by the British Fertility Society and by our own Professor Joyce Harper. And it was recently added to the school curriculum. Another thing that really struck me working as an obstetrician looking after the IVF patients was the tragedy of multiple pregnancy. It was commonplace at that time to transfer 3 embryos. The multiple birth rate was 27%. Twins are 6 or 7 times more likely to die after birth or to have cerebral palsy. And in the early 2000s, I was one of a group of fertility and public health experts commissioned to report on these risks. The One at a Time report was launched 2007. You can see the effect. It encouraged clinics to transfer a single embryo and freeze the others for later use. Then I was appointed to the NICE Fertility Guideline Committee, 2011, and I led the topic of embryo transfer. And the recommendations that we made reduced multiple pregnancy, but didn't impact the patient's overall chance of having a baby. Really, this has been a huge public policy success. Now, there were several reports of increased ovarian cancer after fertility treatment. We published an early study, 2009, using ovulation induction records from the Middlesex and the Royal Free. They went back 20 years. But in these 2 papers, Dr. Carrie Williams and Professor Alistair Sutcliffe, my colleagues at UCL, looked at much larger cohorts. And we had 2 major publications. This in the New England Journal looked at over 100,000 children born from assisted conception in the UK and linked them to cancer registry details. We found no overall increased risk of cancer. More important to me as a gynecologist, but surprisingly much harder to publish, was the study of women. We had more than 250,000 women in this report, recorded in the HFVA database. They'd all had IVF and they were followed up a median of 9 years, so a reasonable length of time. And there were increased risks of invasive and borderline ovarian tumors. But the subgroup analysis suggested that actually this was associated with the reason for IVF. It was pelvic pathology and especially endometriosis rather than the IVF itself. Sorry. Oh, yeah, easily forgiven. But anyway, ethics, you can see that. I mean, ethical problems have run through the work of assisted reproduction, haven't they? They've actually driven the law and regulation. And just a couple of examples. This here is an advert from a student newspaper in Berkeley, California. It's advertising for students to donate their eggs for $15,000, and that was 20 years ago. This is the European Parliament. The MEPs were debating surrogacy and cloning. And when it came to cloning, they all put on identical masks. And this is surrogacy. There was a real scandal for a time about commercialization of surrogacy in India. And there was a big problem not that long ago in Ukraine, actually. And by now, you've probably all read this newspaper clipping from the beginning of my career. This is about grandparents whose daughter died from cancer, but created her child from her frozen eggs. So there's a lot to think about ethically in our field, and I've got 2 roles where I've tried to contribute. I was delighted to join the Progress Educational Trust, a brilliant organisation that runs public meetings and online discussions. Please have a look at their website afterwards. And thank you, Sarah Norcross, who's hiding in the audience, who's their director. I also spent 10 years working as a medical advisor for the Human Fertilisation and Embryology Authority. They are our regulator in the UK. And I was involved in setting up a traffic light system to give guidance to patients about which add-on treatments are evidence-based, not many, I think in fact, perhaps none, which are useless, which are perhaps even scams or harmful. I think now it's perhaps a little overcomplicated. Traffic lights usually have only 3 lights, which is what we did at the beginning. But still, I think it's been helpful. And oh, finally, this was in the paper just a week ago. Reproductive ethics remains and always will be a hot topic. Okay, so I've talked about cancer risk after IVF. What about the use of IVF before cancer treatment? Women who are facing toxic chemotherapy or radiation can store embryos or eggs or ovarian tissue. Actually, I became interested in this while still a senior registrar and did some of the early cases of ovarian tissue freezing. Then, as a consultant, I was responsible for the sperm bank for 10 years. It was the largest sperm storage facility in the country. And this clipping is one of our patients, actually. But for women, it's not as easy as it is for men. The procedures are obviously much more complicated. But I was saddened by the lack of provision for young women, the lack of awareness amongst oncologists, and the lack of joined up pathways to IVF units. So I rang up my friend Richard Anderson and wrote my 3rd BMJ editorial, and actually this is the last to date. So this was to try and give publicity and improve awareness and access to fertility preservation for young women. And one of my better ideas was to set up a network of clinicians. I contacted a few colleagues whom I thought would be interested, and Stuart Lavery, I think you were among them. And after a preliminary chat at the college, in 2016, I arranged a lunchtime meeting during the annual British Fertility Conference. I'd printed out 20 or 25 agendas. We had 50 people turn up. There was standing at the back. And shortly afterwards, we got 100 on the mailing list. So yeah, this was a topic whose time had come. The BFS asked us to become their first special interest group. And this slide just lists the objectives that we set. I wasn't so good at follow through. I learned something about my abilities. It's more about the ideas than the completion. But certainly we have succeeded to some extent. These are the UK guidelines for female fertility preservation published 2018. And I want to give thanks and acknowledgement to Efia Yasmin, who has taken over from me in running the special interest group. And she is an inspiration to all of us. And through NICE, I pushed for this quality standard. These are quite powerful statements because they go to commissioners who can be held to account and to services which can be audited. So we were starting really from nowhere. But in 2021, one of our fellows, Dr. Sanya Latif, did this national survey of fertility preservation provision. And you can see that this map had now entirely turned blue, in that all areas of the UK fund both male and female fertility cryostorage. Most recently, several of us have sat on the NHS England Working Party, led by the wonderful Sheila Lane, which has recently achieved funding for ovarian testicular tissue cryostorage, currently only in those dark blue areas, so that will now spread across the country in the next couple of years. Well, there have been multiple publications on fertility preservation. It's given plenty of projects for our fellows, our MSc students, our IBSc students. And I'm particularly proud of this book, actually. It's a case-based discussions. It's really readable. It's still in print. If any of you would like it, I'll get you a copy. And it won the BMA Oncology Book of the Year. So I thought that was really good for a fertility textbook. And the topics led me into a lot of PPI work, so patient-oriented work, patient organizations, lecturing, helping with patient information like these booklets for Macmillan. And I want to make a shout out for Success, set up by my colleague Helen Spadeus for the survivors of childhood brain tumors. And if you look at her website afterwards, she's doing a sponsored tango. Also, the Cancer, Fertility and Me is a brilliant project led by the lovely Georgina Jones. And this is a decision aid for women facing these really difficult decisions in a tough time. Most recently, our team with Hajra Katak are running a priority setting partnership with patients and carers to identify key areas for future research in this field. Okay, well, moving on. It's only by following patients up you know the outcome of your interventions. And I set up reproductive follow-up services for cancer survivors. This has led to fruitful collaborations, especially with Dr. Panos Kotoridis from Haematology. Panos, I think you know that this is my favorite clinic because it always starts with coffee and buns and a good chat. And in our Macmillan Centre, in the service led by Vicky Grandage, there's a cohort of more than 1,000 young patients from Great Ormond Street, survivors of childhood cancer. And I also get many referrals from the Royal Marsden in Sutton. So we have a huge amount of data, and this project is now just waiting for the time to do it. What we are doing at the moment is we're running a study of pregnancies after bone marrow transplant, including national data collection through UK obstetric surveillance. And I'm chairing the steering group for UK Store, which is a national registry of stored tissue. Okay, well, long-term reproductive outcomes were a theme in my clinical work. They've certainly fueled my academic interests. And I've got a special place in my heart for treating women with Turner syndrome. Adolescence is a time of transition, both physically and psychologically. And children with chronic health problems often get lost when they move to adult care. They either don't attend or they stop taking their treatments. I was a founder member of BRITSPAG, the British Society for Paediatric and Adolescent Gynaecology, with two other consultants from here, Jimmy Steele, who set up the service at the Middlesex for congenital anomalies, and his successor, Sarah Crichton. So that was back in '98. And after writing this editorial for the British Journal 2009, I set up an endocrine transition clinic, my colleague Caroline Brain, who is watching one of her children do a triathlon this evening. But that clinic's been an absolute joy. We've done some work on puberty in girls who need hormone treatment. We looked at adult outcomes, and we could see the long-term influence from age at diagnosis and starting estrogen. It even extends to success rates from fertility treatment because of uterine growth. My colleague Liz Burt has done research on this. She showed lots of individual variation to the same estrogen dose. There's a lot still to be done here. So there are more papers than I could show here, and I've probably started to bore the audience already. But very recently, actually last week, two of our medical students had posters presented at the European Fertility Meeting. So that's a great takeoff for their academic careers. And my research fellow, Zach Nash, gave a wonderfully assured presentation on the stability of ovarian function in menstruating women with Turner syndrome. So Zach, I hope if you're online, thank you very, very much. And it's highly relevant to the current drive for fertility preservation in young people with Turner syndrome, which has been controversial and, in my opinion, at times quite unethical. So I muscled in on this meeting in Aarhus last summer to contribute to the international guidelines, which were published in May. So the care of women with Turner syndrome's transformed in my career. We owe it to one of our patients, Angela Merry, who made many visits to us and stimulated the specialist clinics around the country. I've been going to the Support Society meetings for years and want to say thank you to Arlene Smythe, who again is watching online, as being an incredible example leading a patient service. Now, the TSSS very kindly made me their patron last year. I was very touched. And we had a great party. This lot know how to party. The highlight was the Ken and Barbie show, where all of the husbands and fathers came out in their tight t-shirts and their yellow wigs. It was great. We were all on the stage. Anyway, more seriously, in a change of tack, I've mentioned guidelines several times, and research appraisal and evidence-based medicine is an important part of my academic work. I was chair of the RCOG guideline committee at a formative time. I commissioned some quite important topics. HIV in pregnancy. Thromboprophylaxis probably isn't doesn't hit the headlines, but actually that guidance has saved lives. And the college guidelines became highly appreciated and were very influential overseas. Early on, I felt they should be available to patients, so I went to council and managed to make the case to employ a writer to translate the information into readable topics. So I didn't manage to get high office at the college or the CD post here, though actually I think not being the clinical director might have been a lucky escape. I wouldn't have been very good at it. But instead, I became clinical director of the NICE Women's Health Guideline Programme. And it wasn't such a geeky role as it sounds, actually. I'm not a methodologist. Don't ask me to explain network meta-analysis. What I was good at was being a sensible clinician. So for topics, it was important to know what the issues were when writing the scope. It was important to know who the key players were when you were recruiting a committee, and know who could give a balanced opinion when it ran into conflict. And we did do some tricky ones. We did abortion and mesh and got through. I've contributed to lots of other guidelines for specialist societies. And this one was quite special. I co-chaired this with Lisa Webber, and it was an international guideline on premature ovarian insufficiency, which has over 1,000 citations. It's been another long-standing clinical interest. This goes back to the early research. This is a paper with Jerry Conway in '96, 2012, 2017, and actually this last one is earlier this year, a review article in the British Medical Journal with Dr. Nash. We're currently updating the POI guideline, and the ESHRA group is now really international because it includes, well, I won't name them all, but it includes representatives from America, Australia, China, as well as Europe. So it's going to be an international consensus. Okay, despite all of this work, we still don't know what is the best type of treatment for young women with ovarian insufficiency. They may take estrogen for 30 years. So this was a question that bothered me in my daily practice. I fell into researching it by mistake. I was chatting at the British Menopause Society, and it turned out they had no one free to attend a research meeting. I said, no, I think you should send a representative, because if you don't, you may never be invited back. So they turned around and said, okay, well, you go then. And it was just down the road, and it was my SPA session. And I had 2 strokes of luck that day in 2016. Firstly, I sat next to Jane Daniels, who is now Professor of Clinical Trials in Nottingham. And she has been a great collaborator. Secondly, I listened to a speaker from NIHR, and I thought, this isn't so hard. So I put together this research question that bothered me as a PICO. Literally, it's on a sheet of A4, sent it in, they picked it up, and sometime later it came out as a commission call. So seeing that, I thought, well, you know, we've gone this far, we better bid for it, and put together a lovely group of colleagues. And I can honestly say it wasn't that difficult. Certainly not as hard as trying to get your NHS clinics supported. Well, I feel awkward saying that, but you know, there's a whole system of support in the world of academia. It may not move very slowly. It took us another 4 years, I think, to get this trial up and going. But it's a well-worn path. And I should say to all of you who don't have a conventional academic career, don't be frightened, just have a go. Anyway, the POISE trial is now recruiting. We've got 23 sites from Aberdeen up there, down to Salisbury down here, and Southampton's about to open. And we've got over 100 participants, so fingers crossed we might manage to complete it. My other NIHR award is for non-hormonal treatments for hot flushes. There are many women who are symptomatic but can't take HRT, especially those with breast cancer, and endocrine therapy can cause very severe symptoms. There are also lots of women who don't want to take HRT, but they'd like some help. So this was a topic commissioned by NIHR, but it's run into some headwinds. The study drug is unavailable. Well, we'd already got everything set up to start. We'd done the first dozen site visits. We can't abandon it now. So I'm hoping to change our flight path to study fezolinetant. This is the new kid on the block. It's a neurokinin 3 receptor antagonist. That means it acts centrally, somewhere in the hypothalamus on your thermal regulatory center. And it was licensed last year in the States, in the UK in December, but it's not yet available on the NHS. It's going to have to be appraised by NICE starting later this year. So I think a comparative trial is needed. It seems to have similar efficacy to the existing non-hormonal agents. It's got a better side effect profile, but it's much more expensive. And in the States, it was marketed above $400 a month. They've said in the NHS, the price might be £44 a month. So I don't know how that naught disappeared quite so easily. And I'll just finally mention 2 other research plans. Firstly, we need a lot more work on early menopause. We need to know the health implications for bones, heart, cognition. This article down here came out in the Lancet on International Women's Day in a group of papers edited by Martha Hickey. Thank you very much for coming, Martha. And this really drew attention to menopause. In fact, it sparked slightly controversial discussion, didn't it, about empowerment, medicalization, and commercialization of the menopause. But all publicity is good. Secondly, I hope to support the menopause education program being set up at UCL by my colleagues Shima Tariq, Joyce Harper, and Nikki Key. It got great publicity in the House of Commons recently with the MP Caroline Harris, who leads the APPG on menopause. It's going to be called In Tune, so please watch this space. Now, I've kept the best till last. Teaching and training. This is the icing on the cake of one's career. I think it's the most enjoyable and rewarding thing to see people come through, learn from them, and actually seeing young people in the department. It's so important for as you become a more senior member, and it's really nice when they still take you to the pub after work. Having been myself one of the first 3 subspecialty trainees, I set up subspecialty training here as soon as I was appointed and personally supervised at least 12 trainees. I ended up chair of the RCOG Subspecialty Training Committee and had to steer it through COVID pandemic. So 2 of these ex-trainees are now UCLH consultants. There's Efia and Dimitri Mavrelos. Perhaps it's too much to name all 12, but when I asked for photographs, I had some lovely messages back, including one from Roger, who's down there in the corner. He's held a chair for at least 10 years in Australia, and he just said, oh, about bloody time. And it's a great joy that Caroline could be here today. Thank you. So I want to say thank you to all my trainees. It's been such a pleasure to work with you. And thanks also to colleagues in reproductive medicine. I dug out a rather good old photograph. And you can, again, see here Jerry Conway, just not so keen on photos. You can see Roy Homburg there. And Roy, thank you so much. I'm so delighted you've joined us recently. My old friend Adam Balin. You can see Steve Franks, Mark Hamilton, Bill Ledger, and Leslie Regan standing next to me. So there was a big Middlesex connection there too. And I want to just finish with thank yous to, it's a long list, senior colleagues at UCH, the colleagues with whom I do joint clinics, endocrinology, haematology, paediatrics, metabolic medicine. It's been great. Our fellows, our trainees, and our nursing colleagues and our admin staff. And this is my final photo. I like this because I spent a lot of effort in my career removing the barriers for women in medicine. And when I look at these wonderful, talented young colleagues, I'm so proud of them. So here's to the next generation. Just remember, KBO, and you'll be flying. Thank you.
Good evening, everybody. My name's Stuart Lavery. I'm DCD here at UCLH. And I just wanted to, on everybody's behalf, thank Melanie, not just for the amazing tour de force presentation that she's given us this evening, but really for everything that she's done for our profession, for our institution, and for our patients. That was a really humbling presentation. How one manages to pack that amount of work into one career is quite amazing.
But I'm quite old, Stuart.
Well, I just think that photograph that you showed of the fertility giants,
yeah,
that maybe there might be room for one more person in that photograph. But Melanie really represents, you know, everything in our department that's really good about the NHS. She's academic, she does great research, she's amazing training the juniors. In fact, she's an inspiration to the junior team. And she's great for us when we need a bit of wise advice, we need a bit of experience, we need somebody to keep us on the straight and narrow. And Melanie's great at that. You really do represent everything that's great about the hospital and the institution. We're all delighted that you've had this achievement and this recognition. It's truly well deserved. It's amazing when I look around the room and I see some of the people that have come to support this event tonight. And I think it shows you the esteem and the respect that you're held in. Don't go retiring. We still need you. There will be some refreshments served afterwards. I've been promised outside. But please join me once more in congratulating Melanie on her great achievement.